Thank you for joining. On behalf of the Riverside County Medical Association and the Inland Empire Foundation for Medical Care, I'd like to thank you for being with us today. I'd like to begin by extending appreciation to Dolores Green, our CEO, for her guidance and inspiration for this series. This presentation is basically part of a larger series that we're presenting over the course of the next few months to help improve the quality and performance of your practice. Next month, I'll be working with Mitzi Young, who is my typical presentation partner, and we'll be working together to talk about how we can optimize practice performance. So let's begin with today's presentation, team-based care. As we start to move forward in our journey toward improving healthcare, it becomes obvious that in many cases there's a great opportunity for improvement. In fact, this is an extraordinary time to really take the opportunity to understand how our practices are performing and to better understand how we can improve not only our performance in terms of quality, but also our efficiency. Undoubtedly, the challenges of practicing medicine today are extraordinary. These are times like we've never seen before. However, while practices have evolved considerably in terms of organization, operations, finance, and many other areas, hospitals and providers are struggling to keep up and trying to understand how they can better serve their communities. We speak to providers every day who are actually struggling to keep their heads above water during the COVID national health emergency. And if any of the predictions are accurate, what we're about to share with you today is even more important as we begin to move forward along this journey. I can tell you it's not easy today. I began practice in the 80s when life was quite a bit simpler. However, we didn't have those requirements, those complicating factors that tend to unnerve us today in the practice of medicine. We didn't have those documentation demands that you now see today that can often unnerve the best of practices and can increase susceptibility for burnout in our providers. The purpose of our presentation today is really pretty straightforward. It's to help you go from where you are to where you want to be or need to be. What we hope to do is to lay out a pathway that can help you evolve as a practice to not only improve the quality of life for your patients, but also to improve quality of life for your providers and staff. One of the key things that we really have to mention here is that we often talk about healthcare as something that we deliver because we are the providers. We're the staff, we're the team, we're the ones who deliver that care. However, in order to get this right, we really have to consider the patient perspective, especially those who are elderly, those with chronic illnesses or life-threatening conditions, and those who are typically overwhelmed. And I can tell you today, more than ever before, as we start to look at the challenges patients are facing, it becomes all too obvious that we can all do better. I was speaking with a highly respected colleague today who was sharing that her parents were going through a host of challenges getting the type of care that they needed. And in fact, it became apparent that healthcare for them was confusing, fragmented, frustrating, and at times frightening. In fact, the waiting game for them was more unnerving than not. It was also believed that one of the admissions that occurred was based upon that unnerving sense of frustration that evolved out of not being able to get the care that was needed when they needed it. The bottom line is that we have to consider what the patient and what the family is experiencing. And we have to look to this as an opportunity to come together and reduce the intimidation and the disheartening sense that many of our patients face. I can tell you as a healthcare provider, it hasn't been that difficult for me to get the care that I need for my family. And I would suppose it would be the same for most of you. But if you don't have an advocate, if you're not working closely with someone who understands the system, it can be extraordinarily difficult from the patient perspective. When we start to consider not only advancing ourselves, but advancing the care that we provide for patients, we realize that individuals are placing their trust in us. And we have to, as organized medicine, enable them to move from where they are to where they need to be as well. I can tell you that perhaps the best way of doing it is to redesign our philosophical approach and to say to ourselves, what is the culture that we need to adopt in order to provide better care? And that's really where this topic comes in. Team-based care. And I'm going to read, this is defined by the National Academy of Medicine, formerly the Institute of Medicine, as the provision of health services to individuals, families, and communities by at least two health providers who work collaboratively with patients and their caregivers to the extent preferred by each patient. And the idea here is really to accomplish those shared goals within and across settings and to achieve coordinated, high-quality care. Now, I want to take apart this definition because I think it's really important that you realize that one size doesn't fit all. There are some people who are obviously adept at fending for themselves, and they do extraordinarily well in the context of being able to move the healthcare system or work with the healthcare system in a way that makes sense for them. There are a lot of people, especially younger people, who were extraordinarily pleased with telehealth based upon the potential of not having to actually wait in a busy doctor's office or expose themselves to other types of contagious illnesses. On the other hand, there are older individuals who need more hand-holding. And these are typically individuals who are threatened with chronic conditions. And if we take it to the extreme, the at-risk elderly, who are the dual patients, meaning those on both Medicare and Medi-Cal. The idea here, however, is the team-based concept relies on more than one person being responsible for that patient's care, and it provides an extraordinary opportunity for us to put those teams together. As we move through this collectively, we have to realize that this is truly not a new concept. When we started out and we looked at where we were, it became apparent back in 2016 that the AHRQ, that's the Agency for Healthcare Research and Quality, was rather focused on this as well. And they basically addressed it from the patient-centered team approach in primary care. And I'm not going to read this to you, you can see all the values, but the bottom line was you really start with a sense of putting a team together, developing a sense of patient centricity, where the orientation is toward the whole person, and then developing not only better healthcare, but also producing greater value, efficiency, effectiveness, and satisfaction of both patients. And I want to emphasize this, providers. I keep on coming back to providers because I think one of the major contributing factors to burnout, which is becoming all too pervasive today, is the fact that from a realistic perspective, the practice of medicine may not be as satisfying as we initially anticipated. And as we start to realize that as our practice evolves, it has a tendency to become more troublesome, more complicated, more frustrating. And I'm not talking about for patients, I'm talking about for us. And when that sense of accomplishment seems to wane, and we have to ask ourselves why we're doing this and go back to why we actually got into medicine, that's when we have to realize that what we're really doing is we're taking the pulse of our own consciousness. We're realizing that we're already in that loop that could exacerbate into burnout. So as a physician, I'm really concerned with the fact that we do everything not only to safeguard the well-being of our patients, but we do exactly the same thing with our providers, and even more importantly, with the office staff. Because if you have a highly functioning office staff and everything is going well, I believe the chances of burnout are a heck of a lot less. However, if the way the office is run is somewhat dysfunctional and you're constantly challenged and you don't have the protocols and workflows in play to make this work like a well-oiled machine, then the tendency for burnout increases as well. Bottom line here is what I'm suggesting is doing the right thing for the right reasons and looking at the entire spectrum of care with the patient at the center, surrounded by their family, surrounded by those practices, with a sense that the patient is an active and meaningful member of the healthcare team. And I know you've heard this over and over before, but the reality is we get caught up in the busyness of our day-to-day activity, and sometimes we forget. As we proceed further, it becomes all too apparent that many physicians absolutely believe that this is not the right thing to do, that this is really not the direction we should be moving in, that this is not the humanistic way to treat patients, because of the fact that they believe something important will be lost. And that special something we often refer to as relational continuity. And what that means is that sense of a caring relationship where a patient is known by his or her provider, so that there's a continuum, a sense of being linked to current care, and an expectation that that physician, that provider will be with them always. And I can tell you that's pretty much how medicine was 30 or 40 years ago. But as healthcare became more complex, as specialization became greater, as the demands for practices started to improve, it became readily apparent that healthcare had to change as well. Years ago, I had an opportunity to speak to two phenomenal programmers from India. And we were talking about population health, and they came to me. In my former position, I was leading population health for a number of hospitals in Pittsburgh. And they said, Dr. Bittman, where do you really think we need to be in healthcare? And of course, I brought up the patient-centered, team-based care. And I said, we still have to maintain that relationship with that patient in a way that they really have confidence that they are with us and that we're looking after them. And they said to me, you know, healthcare has changed a lot in America. And I found that interesting from them because they weren't native-born Americans. But they said, you know, years ago when they came to this country, they remembered the fact that their parents looked at healthcare in a very different way than they look at it today. He said back then it was almost a social event. When his parents got ready to see the physician, they put on their best Sunday clothes. They got there, they brought their photo album, and they showed the doctor pictures of their grandchildren and everything else. Bottom line, the evolution of healthcare doesn't really afford the opportunity to do that today. And because of that, the sense of losing that relationship with the patient is often what tempers our attitudes and our beliefs. However, it was emphasized to me by those two gentlemen that the way that we can counter that is really to find a way to establish continuity of care. And that's really what we're talking about here. We're talking about establishing relational continuity with a team rather than with one sole provider. So let's take this another step. How do we move past this? How do you take a patient who's been seeing you for the last 10 or 15 years and suddenly is dismayed with the fact that they're no longer seeing you at each visit, that they're actually seeing the nurse practitioner or the PA or another member of your team? How do you work this through your practice and deal with the expectation? And I think this is an exercise that all of us should participate in. It's really developing a team-based practice philosophy statement. And the way to do this is not by sitting, at home in your den on a Sunday morning, But my recommendation is you actually do this with your entire office staff. You turn it into a lunch session, and you buy lunch, of course. But what you actually do is give them an opportunity to talk about what's most important and what defines your practice in terms of that philosophy statement. And once you've developed it, and of course it has to be focused in a way that fully explains that relationship, that new relationship with a team that's encircling you, that's caring about you, that's really focused on your well-being all the time, that provides that safety net for all of your needs, then you really have to put it into a statement. And once you put it into a statement, you have to start dreaming it, you have to start living it, and you have to start practicing it. You have to share it with your patients. You have to use it as the basis for everything you do in your practice. In fact, I would suggest using it for building job descriptions, hiring personnel, and actually operations within your practice. I think the most important aspect of this is that the patient is a valued member on their healthcare team. And this has to be done with a great deal of finesse because you have to ensure cultural competency. You have to make sure that this is presented in a way that your patients understand. And most importantly, when you adopt this statement, it has to resonate as your culture. And my suggestion is to use it as your practice mantra. Really make it your credo, make it your sense of why you exist, and exemplify the fact that your patients are not just getting cared for by you, but by a highly adept team that's caring and dedicated and totally focused on their well-being. And that's probably, the essence of this. But what's really important is the exercise in sitting down with your staff and making sure that they have a major part in developing this statement. So, where do we go from here? I think one of the most important aspects of our work is realizing that it's not just developing a mantra or a statement, it's really living it. It's developing a team-based approach. A team-based approach that's affordable to your practice, something that's efficient, something that enables you to refine your service in a way that truly generates value and not waste. And I want you to know, I often refer back to the Toyota production system, because this is really where this type of concept of value stream mapping actually began. And for those of you who are into lean, you probably realize that this is one of the foundational lean elements. It's essentially taking your strategy or your workflow and putting it on steroids. But it's not really difficult to do, because the added element here, which we often forget, is our most valuable asset. And I have news for you, it's not money. Our most valuable asset is time. So what value stream mapping does is it takes those plans, it takes those workflows, and assigns a time element. As Ellen Noel from Virginia Mason stated, mapping a value stream allows teams to get at the truth. It helps us observe our processes to discover what's really going on in our patient's journey. Now, I want you to know this works two ways, and this is really critical to your understanding of value stream mapping. This is not only to provide expedience for ourselves, not only for us to refine our processes, but also to improve that patient experience. And getting back to that example that I mentioned before, if you have an individual with a known condition that needs surgery, that individual might wait 3 or 4 weeks to see the physician. And at the end of 4 weeks, they get to see their doctor. Their doctor sits down with them and says, yes, you need the surgery, which they were anticipating, but now you need cardiac clearance. So we're going to send you to a cardiologist. And that's a typical part of our workflow. The only problem is it takes another 4 weeks to get into the cardiologist. I think you get what I'm saying. There's a lot of wasted time. And with wasted time, there's frustration. And I can tell you, not only is there frustration, but there's a greater chance for something to go wrong, especially when a patient needs and could benefit from a procedure. The bottom line for all of this is, as we move forward, we have to start to consider the entire practice. We have to consider what's happening. We have to consider the entire stream of work. And what I'm doing over here is I'm really just showing you what a very simple process looks like if you break it down. And this is a simple exercise that you can do. And again, a great time to do this is during your lunch break. And look at the various steps it takes to actually see a patient. It's that initial conversation. It's the preparation. And I'm not going to go through all the steps. These are different for all of your practices. This is just an example. But you are actually going through these, and you have to say to yourself, is there a better way of doing it? Then you get the forms back. You have to verify them. You look at insurance, and the patient is standing in front of you, and you have to get the person into the queue and assign a room. And these are all the basic things that we all do every day of the week. Then as a provider, you really want that patient to be prepped for you. So you typically have a medical assistant or nurse go in, bed the patient, sit down and speak with them, find out what their chief complaint is, review their history, perhaps their review of systems, perhaps their care gaps. I want you to know that not every practice does this. Sometimes it's simply going from the waiting room to see the physician, and the patient is in and out in just a few minutes. Once that provider preparation has occurred, assuming that it has, then the physician, the PA, or the NP actually gets to see the patient, and they review the forms. They do an evaluation or examination, perhaps. They put forth the orders. And in a team-based model, they establish what I call ancillary assignment. What does that patient have to see in your practice? Do you have a counselor? Do you have a social worker? Do you have another individual that they should see? Do you have a nutritionist on staff? Is there a coordinator? And then, of course, when those ancillaries come into play, then you have to go through the process over and over again. Ultimately, after everyone's seen the patient and reviewed the patient, you obviously have your workup, your referrals, your review, and your follow-up set up for that patient. If you're doing this as a team, you basically review the case or that individual in team-based meetings. You develop a prevention and treatment plan, and certainly that comes into play for scheduling the subsequent visits. It's difficult to do when you're presenting in a webinar format like this, but my question for you, I'd like you to keep this in the back of your mind, is what steps could be combined? How can we best do this? Does the patient have to see the medical assistant, the actual provider, and the ancillaries during each visit? Can the preparation aspect of this be blended into another step? And can there be a unified strategy for taking certain types of patients and providing the care that they need? Now, I truly believe in the patient-centered medical home, but one of the things that I'm really not keen on is the fact that you have to do absolutely everything for everyone. So the bottom line is you have patients who are chronically ill and stable. You have individuals who are chronically ill and unstable. You have patients with acute life-threatening illnesses, and you have routine patients that typically come in when they become acutely symptomatic. So the question is, how does this workflow or the value stream map work with each type of patient that you have in your practice? Remember what I said from the start, one size does not fit all. Let's talk for a few seconds about team assignments in team-based care. And this is truly important because what I really believe is that you have to be careful in establishing the demarcations. What do I mean by that? You're probably saying to yourself, I can't afford an extra nurse and a nutritionist and a counselor. Well, that may be the case. On the other hand, there's some good arguments that by amplifying your staff, you can actually do rather well. There was an article in Review Cycle Intelligence just today that showed that the best performing practices typically have 9 to 10% more overhead. And I know what you're thinking, I can't afford 9 or 10% more overhead. But on average, they had 30% more productivity and patient volume, and improvements in care or outcomes were typically in the 10 to 12% range. So we probably think you can't afford this. In another sense, perhaps you can't afford not to do this. But back to the team members and their roles, some degree of overlap should exist. And that's where team meetings come in. Because the nurse is going to pick up some tips on nutrition. The nutritionist is going to pick up some tips on counseling or guiding the patients and so on. And before you know it, there's a certain amount of overlap, which enables your staff to cover for itself. And that's really important. If one person is out or on vacation, you don't want to lose that team-based care flow. I think that there are certain elements that are uniformly required across the board. But again, others are optional. So for example, if I wanted my flu shot and I called my physician rather than going to a pharmacy, and the staff looked at it and said, well, Dr. Bittman had his annual wellness visit and he's been taking his medications, he's gotten the appropriate refills and so on. The way that the appointment would be set up for me would be totally different than the patient who is 79 years old, has COPD, diabetes, and has been in and out of the hospital. So again, one size doesn't fit all. Now, this is really critical here, and I see this mistake more often than not. When the evolution of PAs and NPs, or certified nurse practitioners, came into vogue, I really thought this was a major step in healthcare. But I realized rather quickly that in fact it wasn't, because instead of using or incorporating these professionals into the practice of medicine, we simply use them, and I hate this term, as quote unquote extenders. So an extender is basically someone who enables you to see more patients, establish more throughput, and do more volume. And as you know, today we're focused more on outcomes than volume. So the real question is, how do you assign the right person to the right patient? Or is your practice working on the premise that the next person that calls in is going to get the next available slot from any team member that you have? This is really important. And what has to be understood here through your mantra, through your statement, through your communication with your patient, is that the physician, PA, NP, or ancillary staff may not see the patient at each visit. In fact, it might only be one person, even though it's team-based care. So I think that's critical as we move forward. So I'm going to show you one of my favorite diagrams that I've used over the years to look at a typical PCP practice. So if you look at the top part of the model, you can see, I think there are 32 time slots that are set up all in blue. And those are the typical number of time slots that I'm assuming that this team can see. Now, it's not important that we focus on throughput, because I realize that even though we're not volume focused, we still have to be efficient. But for the sake of argument, let's just agree that there are 32 slots. However, if you start to look at it, you can see that I've color-coded those slots. So the red are low risk, the green are moderate or intermediate risk, the purple are high-risk patients, and you can see there are actually few of them. And turquoise, those are the unscheduled patients that call up and say, you know, you got to get me in today because I'm really sick. If you break this down in figure C, you see how this basically maps out. More than half of your patients fit into the category of low risk. These are patients that don't necessarily need to see a physician. In fact, these are patients who might not benefit from seeing a physician at all. Unfortunately, these are the patients that we often see the most. These are the people that routinely come in. They don't miss their appointments. They show up for their blood pressure checks or their medication levels or whatever. And having your physician see those patients on a regular basis doesn't really make a lot of sense. The green patients are moderate risk patients. And these are individuals that you can classify according to your own criteria. Whatever you choose can work here. But I think it's really important that you look at those with chronic conditions, those who are having particular problems on a chronic basis, those with escalating conditions, and those individuals will have to be treated in a different way. Now, your decision of whether or not these should be seen by the physician versus the PA or the NP is really up to you. So stick with me, there's a method to my madness. Out of the entire day, there are only 4 patients that really are high risk. And frankly, you should probably see them as the main provider. You're the one who should make sure that those patients are the ones that go to you. While you're in the office, you can certainly supervise the care for those other patients, but these are the ones who are really not very stable. And these are the patients who are particularly vulnerable. An example is a patient who's been to the emergency room 2 or 3 times in the last couple of weeks, who is now in front of you in your office, and you have to decide on a practical treatment plan to keep them healthy, but also try to prevent unnecessary utilization. So those purple patients really should be yours. And finally, those turquoise patients, those are the unscheduled ones. I have a really bad sore throat today. I have a horrible earache. My child is sick. I got to get them in, and so on. You should develop a workflow for those individuals with a series of questions that your office staff and manager perhaps can handle, where they can make the decision on which practitioner that patient should be assigned to. Now, I know what you're thinking. We don't have any available slots in our practice because we're super busy, and you're asking us to take these extra steps. What I'm actually saying is if you do this and you reorganize your practice to team-based care and you start to do your own risk stratification for patients, you actually clear up your schedule in a way that truly is meaningful and you become more efficient. As we start to move through this, you realize that this is a different philosophy. And we'll go through the elements. From personnel, traditionally we wanted to hire the most qualified person. That makes a great deal of sense. But now, when you're talking about team-based care, you want to get that person who can work effectively as a team member. And I want you to know that not everyone can. The patient assignment used to be provider-based. Now it really has to be team-based. Even though a patient may be assigned to you as a provider, an NP, a PA, that next visit might be better handled by the counselor in your practice. The care plans used to be developed by the single provider. Now the care plans are developed by the team and the patient. And you're probably saying, where do we get the time for this? Well, we used to do this in lunch breaks, or we used to basically assign a half an hour to being able to make it work. Or you could do stand-up rounds in the morning where you take 10 minutes to talk about the patients who have been to the ED, who are unstable, who are being discharged from the hospital, or the ones that you're worried about. And you basically work together to come up with the best strategy. Care coordination was unheard of classically. Now it's both internal and shared. What do I mean by that? Every member of the team is looking at how to establish continuity of care and how to work with outside agencies to make sure that your patient is effectively cared for. Your extender value, again, as I mentioned before, was volume-based. Now it's quality-based. If we assign the right patients to the right people, can we improve quality outcomes? And can we become more self-organizing and at the same time efficient? Information sharing was basically the provider of the patient, maybe some intermittent staff support, typically coming from an office manager. Now it's really a team-based concept. This is a team-based sport. And everyone that comes in contact with that patient during the course of your office encounter should be talking to that patient and should be reinforcing that message of team-based care. And I want to digress for a second because I want you to know we use this in business, but not so much in healthcare. And it's called managing up. And how does that work? It basically works by the fact that you're the provider and you're working with the patient and you say to the patient, in 1 month, I want you to see my PA who's going to work with you. And the patient's saying to themselves, well, I don't know who this person is. I don't have a relationship with them or whatever. But then this is the managing up part. You say to the patient, I want you to know this is one of the most incredible people I've ever worked with. This person is caring. This person is dedicated. This person communicates with me every single day. And this person does not let anything slip through the cracks. So I want you to know you're in great hands. That creates an entirely different perspective than saying, in 1 month, I want you to see my PA. So I really think you have to manage up. And I think the real part of this whole thing that has to be gained is a sense of trust with the patient. Warm handoffs, a focus on cohesion, and also a sense of trust within the team itself. I want you to know, classically, we've dealt with challenges in a piecemeal fashion. Now we have to try to anticipate them. We have to have continuity of care. We have to know that there's a team on the situation. And if one person is overwhelmed and can't deal with it today, another member of the team has to step in and work with our patient. So what are the implementation considerations? Well, prior to beginning the process, it's really essential to understand that this is a philosophical and cultural transformation. We have to understand that doing this requires everybody to be on board. This is not just for one person in your practice that decides, hey, this is a great idea, I'm going to try this next week. This is the philosophical construct. And what that means is maybe some of the people that worked for you in the past cannot continue working for you now because they frankly don't get it or buy into it. It's up to you. Another big deterrent to this are the financial considerations. You're probably saying to yourself, my God, I really can't afford this. This is really difficult. But in many cases, there's the makings of a team already in your practice. You're just not working with those individuals in this way. If you have to employ additional staff, their salaries and overhead have to be considered. But I want you to know, in most cases, those can be covered by quality-based performance incentives, which you can gain by improving your overall practice. And as I mentioned before in that article today, if you spend 9% more based upon the article in Rev Cycle Intelligence, you're probably going to get that back in spades. It's probably going to improve your practice efficiency. It's going to help increase your revenue and help your bottom line. So I want you to know that we're not only talking about better care, we're talking about improving the overall efficiency of your practice and potentially practice earnings. So what are our final considerations? Well, one, I think team-based care is an essential spoke in the hub of healthcare transformation. You know, everybody thinks we're going to come up with a single payer system and that's going to fix everything. That's not going to happen. And I'm not supporting a single payer system or not. But what I'm saying is that ground up transformation has to happen, and it's up to us to do it. We have to adopt a new philosophy, and we have to make it our culture. We have to focus on quadruple aim objectives, meaning better outcomes, better experiences of care, potentially preventable expenditures to be eliminated, and reducing burnout for our providers. The responsibility of all of this does not exist only within your walls. We have to look at healthcare as a continuum of care and an overall responsibility that we assume for our patients and their families. Perhaps the biggest element here is trust, and that's conditioned on quality and commitment of your team members, your ability to work together, to support together, to really act as a team. But you also have to create that trust with the patient. And that's why your practice statement is so critical. You have to live it, you have to drink it, you have to breathe it. Finally, effective processes and workflows must be in play and carefully monitored. You can't begin something like this today and say, well, I'm excited about it and let's see if it works. And 3 months from now, you're back at the old way of doing things. This requires continuous quality improvement and monitoring. And it's something that can give you as a leader a great deal of satisfaction because you're seeing the type of transformation that's inspirational on many levels. And as I mentioned before, this could ultimately be the antidote to burnout. This is what can really transform your future as a provider. On our next presentation, we're going to take this a step further. We're going to go into optimizing practice performance. That one's going to be held on November 4th, and I hope you'll join me. With that, I'm going to ask if there are any questions. If not, I want to thank you for being with us today. Again, I'm grateful to Dolores Green and her team for enabling this presentation. I hope that this does plant some seeds and can be the basis of some future transformation. And personally, I look forward to working with all of you in the future. Thank you again. Have a great day.